And now we move to the last session of the day.
Thanks a lot.
For this, I invite moderators Dr. Alok Shinde, Dr. Amit Patil, and Dr. Senthil, and chairpersons Dr. Professor Ajay Mahajan, Dr. Sangvi, and Dr. Rashesh Potiwala. My good friends, welcome, good evening, and over to you, Dr. Mahajan, Dr. Sangvi, to introduce both the speakers next and move ahead with the case presentation scenario and then the debate.
Good evening, Kamal. Thanks for giving the invitation. This is one of the most informative conference. And today, both of my friends, now they are going to discuss very interesting topic at this interesting hour. Dr. Sanjay Shah is a thorough interventional cardiologist, true radialist, working with Dr. Tejas Patel sir. He himself is a big name. Dr. Sanjay Shah is a master in all kinds of radial interventions. He had done maximum radial interventions, and he had published more than 70 papers, more than 79 abstracts, and he had written more than 15 chapters. And he is the best person to defend the today's debate as far as the radial route is concerned. So today's can I introduce other speaker also? So another speaker, Dr. Sharad Jain. He is a very soft-spoken interventional cardiologist from Ahmedabad. He is a thorough gentleman, thorough interventional cardiologist, and he is very aggressive as far as both radial as well as femoral. He himself is a professor of cardiology at UN Mehta Institute of Cardiology. He is having various publications, and he is going to talk as far as the this particular case is a femoral route. So today's case is very interesting. It is a 77-year female with a cardiogenic shock, with chest pain duration of around 5 hours, and she is loaded with Clopidogrel, and she is having RV infarction with a complete heart block. Escape rate is around 34 per minute, and we have to revascularize her with primary PCI. So which route we have to use? So that is the discussion, and this is the ECG of that patient. So may I ask Dr. Sanjay Shah to start his presentation.
So 77 years old patient with acute inferior MI, with RVMI, with window period of 5 hours, with blood pressure of 80 by 55 millimeter of mercury, with past history of hypertension and diabetes, preloaded with Clopidogrel and aspirin, with heart rate of 34 beats per minute, has a complete heart block with symptoms of giddiness. His radials are feeble. The preferred route of PCI would be, of course, radial. Even if the temporary pacemaker is needed, even then the radial route is the preferred modality. Let me tell you, the internal jugular vein access is a default route for PPI at our center. PPI can be easily done using IJV. It is more convenient to the patient as there is a freedom of movement. Lead position is more stable compared to femoral vein. It is a good site for maintaining sterility compared to femoral vein. Let us see what literature says. So this is transjugular insertion of a temporary pacemaker a safe and effective approach? This was published in PLOS 1 to 2020. The aim was to compare the procedure time and complication rates between the transjugular and transfemoral approaches for PPI. Analyze 732 consecutive patients who underwent TPI, from which 361 were in transjugular approach and 371 were in transfemoral approach. The conclusion was the procedure time was significantly shorter in the transjugular approach group. The risk of reposition was significantly more in transfemoral approach group when the temporary pacing was continued for more than 3 days. This is another trial. It's a 5-year study with temporary pacemaker therapy in coronary care unit, published by Mayo Clinic Proceedings, where 1,022 consecutive patients who received temporary transvenous pacemaker in coronary care unit during the 5-year period were studied. And the conclusion was the right internal jugular approach was associated with the lowest complication rate. This was another study, a review of temporary cardiac pacing wires, published in Indian Pacing and Electrophysiology Journal. The aim was to determine the best route of venous access for TPI and find the ways to reduce the complications. 3,700 patients from 15 studies were included. And the results were the internal jugular veins was associated with lowest complication rate and ease of access. The antecubital fossa veins have the highest complication rate. Internal jugular veins are the preferred route for the access, followed by subclavian and femoral veins. The right side should be used whenever it is possible. Guidelines from British Cardiac Society recommend the right internal jugular vein as a route of choice for temporary pacing. Now we all know the advantages of radial route for angioplasty, less incidence of excess site major bleeding and blood transfusions. Major vascular complications are rare. If anatomy is not suitable for PCI, thrombolysis option can be easily offered to the patient as the bleeding risk from pedal site is negligible. This is very important because patient is diabetic since many years. Glycoprotein 2B3A inhibitors can be used without any hesitation. There is no restriction in limb movement after procedure, early ambulation, and the patient with severe LV dysfunctions are not confined to supine position. For experienced radialists, puncture in feeble radial is not a problem. Number of studies have shown morbidity and mortality benefit of radial route in acute MI with cardiogenic shock. Let us see the publications. These are the pooled data of nearly 7,000 patients from 9 studies where major vascular complications were studied, which shows TRI group major complication rate, major vascular complication rate was 0% compared to TFI, it was 3.8%. Radial versus femoral access for rescue PCI with RioPro use. This was published in Canadian Heart Journal. The conclusion was the no access site related major bleeding in radial group versus 9% complication in femoral group. The impact of bleeding, hematoma, and transfusion on the procedure outcome. So this study was published in CCI 2007. The access site hematoma requiring blood transfusion predicts mortality in the patients undergoing percutaneous coronary intervention. This was the data from the National Heart, Lung, and Blood Institute of Dynamic Registry. And the conclusion was the access site complications, especially hematoma requiring transfusion, remains a very important predictor of adverse procedural success and patient outcome. The in-hospital mortality was 9.9% in hematoma group versus 1.2% in non-hematoma group. Impact of major bleeding on 30-day mortality and clinical outcomes in the patient with acute coronary syndrome, published in JACC 2007. The results were patients with major bleeding had higher 30-day rates of mortality, 7.3% versus 1.2% in radial group, and more incidence of stent thrombosis, that was 3.4% in femoral group versus 0.6% in radial group. Conclusion, the major bleeding is a powerful independent predictor of 30-day mortality in patients with ACS managed invasively. Transradial versus transfemoral approach for the percutaneous coronary intervention in cardiogenic shock. This was published in Archives of Cardiovascular Medicine 2015. 101 consecutive patients admitted for PCI for acute MI with cardiogenic shock were treated. 74 patients were in transradial group and 27 patients were in transfemoral. The rates of PCI success were similar in both groups. At the mean follow-up of 756 days, the death occurred in 54.1% patients in transradial group versus 81.5% patients in the transfemoral group. And the conclusion was the transradial approach in the setting of PCI for ischemic cardiogenic shock is associated with dramatic reduction in mortality and should be preferred to the transfemoral approach in the radial expert centers. ACC, AHA, and Society of Cardiovascular Angiography and Intervention guidelines place TRA for PCI in acute coronary syndrome as a class 2A indication with the level of evidence A, and European Society of Cardiology guidelines now place TRA for PCI in acute coronary syndrome as a class 1 indication with the level of evidence A. So clearly choice is IJV route for TPI and radial route for PAMI. Thanks.
Next year we can try Dr. Sanjay to speak on transradial, transfemoral.
Definitely, definitely.
So, good evening. First of all, thank you very much to Kamal for giving me this again an opportunity. And Kamal is just like a younger brother, and we are working together since 20 years. So it is always very good to feel when to come in this conference and present, because it's a very good academic feast, and Kamal is a thorough academician apart from his practice also. As far as Sanjay Bhai is concerned, he is the master of the he's the master radialist. We have learned a lot of things from him. He was just immediate senior to me. So as such, there is no debate as such. Sanjay is always a winner. But still, because this topic has been given to me, so I will just speak some few things for that. So femoral versus radial approach for emergency intubation, the case of femoral approach in radial first era. We all know that the radial first era, even I may go for radial first. So just coming, तुम्हारे उसूल तुम्हारे आदर्श किस काम के तुम्हारे उसूल. So this I will discuss it later also again. So as the scenario has already been discussed, 77-year-old female.
Your slides are not moving. We can't see your slides.
Coming to the as already case scenario has already been discussed. The important point is radials are feeble, although it is in the hands of Sanjay. It is because he's so expert. It is with the blood pressure of 80, he can take easily radials. For it is not easy for everyone to take the radial with this blood pressure in cardiogenic shock, especially in a 77-year-old female patient, especially with those so many young cardiologists now they are there. So as far as this even the has already been discussed, ESC and all recommends the radial as the first route. However, same has not been studied widely in the second setting of cardiogenic shock and high-risk PCI. Already, as Sanjay Bhai has discussed one study in which there are 100 patients with cardiogenic shock. But if you go through the literature, various trials that radials, rival, and all these semi-radial, all they excluded patient with the cardiogenic shock in the study. Exclusion criteria were this one. So coming to the PCI seminar, the management of patient with high-risk acute coronary syndrome. In a STEMI patient, we all know that the time is muscle. With your experience, you should estimate yourself own that whether you will be able to do with the radial, especially those who are less experienced. So in a STEMI patient treated with an aggressive antiplatelet and antithrombotic, we all know that radial reduces the bleeding complications were performed just by experienced operator. The use of the femoral approach is preferred in hemodynamically unstable patient, and when you need a very rapid fast recalculation, especially if the you need large catheters and need lot of support. The radial axis with 6 French sheath will not give that much of support. So coming to a very important trial which is published, which has been in the JCC 2019, the Safari STEMI trial, which was conducted at 5 centers in Canada. For seeing whether the aim was whether determine if the radial axis improves survival when compared to the femoral axis in patient referred for primary PCI, because various previous trials say that radial axis is associated with lower mortality in STEMI patient. So just to confirm that. So the primary outcome of this trial was the all-cause mortality measured at 30 days, and the key secondary outcomes for the 30 days: the stroke, reinfarction, stent thrombosis, bleeding. So if you see the primary outcome, the 30-day mortality was almost similar in both the groups, femoral or radial axis in this trial. This trial included all kinds of patients and experienced operators, both for the radial and the femoral route. And the bleeding was definitely slightly higher, but not statistically significant in the radial group, in the femoral group as compared to the radial group. The conclusion of the trial was in patient with STEMI referred for primary PCI, we did not find a difference in survival at 30 days between the use of radial axis and femoral axis. Our findings suggest that adequately trained operators should be able to achieve similar results using either radial or femoral axis for primary PCI. So you can, we all know the complications of various radial and the femoral routes, the common complications. But if you see the radial arterial anatomical variants, which are which might be cumbersome, especially in the emergency situation, in a 77-year-old female, like complex radial arterial loop, then anatomical difficulties, and then the tortuous and radial artery with spasm, and the prone to spasm, small caliber radial artery, and then this like lusoria. So this is this can be difficult to, if you see the literature, the anatomical difficulties in the radial approach, that radial anomalies you can find in up to 10% patients, and procedure failure rate is about 15%, those with the anomalies. So advantages of the femoral approach in the emergency situation in the setting of cardiogenic shock: easier to access, being large caliber and no problem of spasm. So it is, even if it is a newcomer, it is relatively easy. Easy delivery of large sheets, and especially if you required IVP in the emergency situation, and even, as I said, the temporary pacing. As Sanjay Bhai said that the transjugular route is good for the venous temporary pacing, I agree with that. But many of us are not experienced of doing temporary pacing with the transjugular route, is because we have been trained in that way that you always did pacing from the femoral route. So especially when you are fumble in the emergency situation, and if you complicate the puncture in the transjugular route, then there can be problems. If you data review on radial versus femoral in the emergency setting, radial versus femoral for rescue PCI, no difference in major bleeding fluoroscopy time, and contrast use was similar, and the times of first balloon inflation was slightly longer with the radial axis. Chinese study on emergency PCI found no difference in outcomes, however, less vascular complications in the radial group. We all know that. UK study on feasibility of radial axis. Then, so why femoral? Studies point to the fact that when radial axis is achieved, it is better in terms of vascular complications, but only non-inferior to femoral axis. But the important thing is you should get the radial. That is that may not be possible with everyone to puncture the radial. Once you puncture the radial, then definitely the vascular complications are less, especially in patient with cardiogenic shock and feeble pulse in a 77-year-old operator. So axis is, as I already said, operator and experience dependent. And if you do it with adequate care, if you do a femoral axis and if you do it carefully, then the produces the same stud result and there is no increased bleeding as compared to the femoral route. So, and if you see the intra-arterial BP and femoral axis, femoral arterial BP are more closely corresponds to central BP. Radial arterial BP underestimates true blood pressure by 15 to 20 mmHg. And you see various studies, the crossover from radial to femoral axis during challenging percutaneous intervention can make the difference between success and failure. And it has been found that the crossover from radial to femoral in various studies is between 6 to 10%. And especially it is more common in the female sex and with the anterior wall MR are the predictors of the crossover. So with the crossover, as it takes more time, so that your door to balloon time increases. So that as we said, the time is in muscle, so that time can get increased. The radiation exposure and vascular axis in acute coronary syndrome, the sub-study from the matrix, that is the red matrix trial, they can just go to the conclusion. Compared to the femoral axis, radial axis is associated with greater operator and patient exposure, radiation exposure, when performed even by the expert operators in current practice. This is not very old, this is 2017 article. So exposure and risk operator, radial operators has more radiation risk as compared to the femoral, but it is also again controversial. Many studies have now shown that the radiation exposure is similar in both. So for radial, if you see the fewer axis complication, if preferable in patient with peripheral vascular disease, patient with morbid obesities, patient having extensive inguinal scarring, severe back pain or shortness of breath, and patient on therapeutic anticoagulation, and patient request, of course, and failed femoral approach. Why femoral? Complex cases, larger catheters and sheaths are required. If you require LV support, TAVR, small radial size, AV fistulas, anatomy, and patient requests. The limitations of the radial route is unpredictable course of to ascending aorta, small radial artery caliber, challenging in cardiogenic shock, increased rate of crossover, radial artery spasm, main culprit to negotiate brachial loop, cardiogenic shock, independent predictor of transradial PCI failure, size of radial artery itself led to sheath occlusion after removal. And radial approach usually requires more learning curve as compared to the femoral approach. No trial rival matrix compared ultrasound guided micropuncture transfemoral arterial puncture versus transradial puncture in reducing vascular complication. Routine use of radial axis create Compeu paradox. When we were the students, it was the femoral only. We have learned it from the femoral to the radial. But now, because of the started with the radial itself, the new residents and that those coming young cardiologists, they are straightway going to the radial route. So the loss of femoral experience, so more femoral vascular complications if you do not have the experience of the femoral puncture. So in conclusion, femoral axis is time tested, easy to apply, particularly in sensitive conditions like cardiogenic shock. Close proximity with femoral vein gives ease for temporary pacing if required, and deploying IBP and other devices can be achieved on femoral route due to large sheath requirement. And of course, with operator experience and due care, vascular complication may be made comparable to the radial approach. So as I already said, तुम्हारे असूल तुम्हारे आदर्श किस काम के हैं तुम्हारे असूल. This is the dialogue from very famous movie of Amitabh Bachchan. So if you when the radial root catheter arrives late at the coronary ostium, I am not talking of Sanjay bhai, he's so experienced and expert, but I am talking of general cardiologists. So my intention not to teach you a method, but just to give good reasoning. Thank you.
Thank you, Sharad and Sanjay. So now the topic is open for discussion. So can I ask some questions to some points from other colleagues? Dr. Senthil, Dr. Sanjay.
I think there is no doubt that the radial approach is the better approach for those who are experienced with it. The experience is the most important thing. For those who have been doing femoral for years together, I think they will be more easy to do from the femoral approach. Especially if the radial is not palpable well and time is very important. But those who are very well experienced like Dr. Sanjay, definitely the radial approach, because we know all the benefits of the radial approach. The complications are less. Even the mortality in meta-analysis has been shown to be less. And of course, the local site complications are much less in radial approach as compared to femoral approach. Recently, we had one patient of inferior wall MI who was done through a femoral approach, but the patient landed up with a hematoma, went into hypertension, required blood transfusion, had a longer stay in the hospital. So all those complications of femoral are definitely there. So most important is the experience of the operator, and it depends on how well he can do it.
Dr. Alok, meanwhile, you can comment your perspective.
Yes, sir. That was a great, great talk from both the speakers, and they are my teachers and they were my examiners also. And so it was nice to see them talk. So I think both had their own perspective and they are right according to them. But I think it's highly operator dependent. I mean, the one who is more comfortable and with femoral approach may choose femoral approach. However, the statistics might be in favor of radial approach. But I think it is more of operator dependent, and whoever is comfortable with whichever approach, that person should choose that route. If femoral is not necessarily harmful, if the puncture is fluoroscopy guided and a careful puncture. But definitely, I think in every case the controls are not in our hands. Like in an obese elderly female, which has I think more prone for hematoma. I think you cannot prevent hematoma even if you take the puncture radiologically. So I think it is operator dependent, but the evidence is more in favor of radial approach. And yes, one should be more very very much acquainted and expert in taking jugular puncture. And in this event of emergency, I think if carotid gets punctured, that can be a nightmare.
Majan sir?
I think the most important thing during the emergency, the jugular puncture. So preferably if you are very confident, then only attempt that, because if there is some mistake, then there will be a major problem. I had seen some patients with carotid hematomas, and that hematomas getting extending to the neck and other problems. So I think when the patient is in cardiogenic shock, with if we are very much accustomed with the temporary pacing through femoral, then we can tie over, because just after opening the artery, that temporary is not required. So in that case also, you can go temporary with the femoral and intervention through radial. So venous puncture from femoral and arterial puncture from radial. So then we can balance both of our today's masters, Dr. Sharad as well as Dr. Sanjay. So that is my take on this case.
So I think, sir, if there are no further comments or questions, we can end the session.
Yes.
Okay.
All right. Thank you very much. At the bottom of my heart, I want to thank each one of you, all the chairpersons and moderators, and both the speakers for wonderful deliberation and presentation. And every year I have to make radial cases more difficult. You know, I have to come with one or the other jugglery to avoid that some way I can pitch it towards femoral. But now the radials have become so common and it's so easy to do that the cases, scenarios have to become more and more complex to make you do femoral.
But Sanjay will do all the complicated. Yes.
Thank you, Kamal. Excellent conference. Thanks for giving this opportunity.
Sir, my pleasure. Thank you for accepting it. Thank you, all of you. Thank you. Good night, everyone. Take care. We catch you up tomorrow again. Thank you. Bye-bye. Join us tomorrow.
Everybody. Goodbye.
Bye. Good night.
Good night.
Good night.
Ajay bhai. Kamal bhai.